Hello, everyone, and welcome to today's webinar, Ask the Experts, Treating Mental Health in the LGBTQIA+ community. I am Dominique Zumwalt. I'm the Senior Copywriter and Managing Editor here at SimplePractice. I'm also today's facilitator. Before we get started, I have a couple of housekeeping things I'd like to go over. This webinar will be recorded, so all registrants will receive an email with the recording. So keep an eye in your inbox. You'll probably get that sometime tomorrow. Also, if you navigate to the GoToWebinar control panel, under the Handouts tab, you'll see a downloadable PDF that includes all of today's slides. Please feel free to look ahead at all the pre-submitted questions we'll be asking our experts today. We're probably not going to be able to get to all of these questions just given the time constraints, but if you see anything that hasn't already yet been asked, please feel free to go to the control panel under the questions tab and submit any questions that you would like to pose to our experts here today. We'll also be using the remaining of our time, probably the last 10 minutes or so, to answer as many live questions as we can get to. So without any further ado, let's jump right in. First, I would like to introduce Dr. Yamonte Cooper. Thank you for being with us today. Tell us a little bit about yourself and your motivation for being here today.
Sure. I am counseling faculty at a local community college, and I am adjunct faculty at a local university, and I am in private practice as well. And my motivation for being here today is really to speak to the experiences of Black LGBTQ+ folks, and also speak to folks of color and their experiences as well.
Excellent. Thank you. Next, I would like to introduce Nina Firooz. Please tell us a little bit about yourself and your motivation for being here today.
Sure. Hi, I'm Nina. Nice to meet everyone. My pronouns are she, her, and hers. I am in full-time private practice, and my practice is centered around the experiences of LGBTQ adults. I have three main focuses in my private practice. One of them is working with both Black and non-Black POC, who are members of the queer community, queer and trans communities. And then I also spent a majority of my therapeutic career working in drug and alcohol treatment, specifically focusing on the needs of LGBTQ folks in recovery. And the other specialty that I have is working with LGBTQ folks who are reconciling faith and sexuality, faith and gender, contending with religious transphobia, religious homophobia, religious biphobia, and working on spiritual pain in regards to that.
Thank you, Nina. And your motivation for being here today?
Oh, thank you. Yes, my motivation for being here today, it's a good question. My motivation for being here today is to speak alongside my fellow panelists, who we each have our own experiences as we embody different intersecting identities. And so for me, part of it is being a queer woman in this space, being a non-Black person of color in this space, and just bringing some of my experience to folks who've registered because they're showing a genuine interest in how do I provide better services to the people who are in my community, and that's really important to me. So that's why I'm here.
Thank you for being here. And last but not least, Kaden Cathers. Please tell us a little bit about your work, what you do, and your motivation for being here today.
I wear a lot of hats. So I am the executive director of the Affirmative Couch, where we provide online continuing education for psychologists about working with LGBTQIA, consensually non-monogamous, kinky clans, the gamut. I'm also affiliate faculty in the LGBT specialization at Antioch University, Los Angeles, and I'm a psych assistant in private practice. supervised by Kenneth Scott, and I focus on psychoanalytic psychotherapy, specifically with transgender and gender non-binary folks. I'm really passionate about teaching and education around particularly transgender affirmative psychotherapy, but LGBT affirmative psychotherapy in general, because I don't think that there's nearly enough training, particularly in our programs, in master's and doctorate programs, around how to work, not just be friendly and open to, but actually work well and work affirmatively, and to celebrate the diversity that LGBTQIA and LGBTQIA with intersectionality, so people of color, LGBTQIA people with disabilities, immigrants, and all of those combinations of working how to work well. There's not enough education, so that's part of the reason I'm here today.
Excellent, thank you so much, and thank you all again for being here today. Before we dive in, I do have one thing that I wanted to mention. Today's pre-submitted questions, they were submitted by registrants, and we intentionally left them as is. We believed it was important to keep the integrity of the question intact, because the way a question is asked contains many nuances and layers, so we wanted to make sure we honored that. And with that said, let's start with our first question. First question is, what does each letter of LGBTQIA+ mean? I know you can all speak to this, but I'd like to start with Kaden, then Yamonte, then Nina.
So the alphabet soup. So we have lesbian, gay, bisexual, transgender, queer, intersex, and asexual or aromantic. And one of the things about the B that needs to be noted is that B often is also used as bi plus to include pansexual, panromantic, and other non-monosexual identities. Trans can also be expanded to be trans and gender non-conforming, as well as including two-spirit identities as well. And the plus is because the acronym keeps growing and growing, and there are more identities that may not be included with all of those umbrella letters.
Is there anything you wanted to add, Yamonte or Nina?
I would just add that it's important to understand that these are very distinct populations under the same umbrella. And so it's important to understand that these are very distinct populations and not a homogeneous population. And I think people often are mistaken about that.
The thing that I would add too is this is something that can be Googled. You do not need to ask experts about this. For anyone who's joining, I really want to empower each and every one of you to ask yourself before you ask someone else, can I Google this? Can I Yahoo this, or whatever? Like, can I just look this up on my own? Am I feeling helpless because I don't know and I'm scared to make a mistake? Spoiler alert, yes, you will make a mistake, and that's okay. So yeah, you can Google it.
Great, thank you guys. Next question goes to Yamonte. What discussions do you want clinicians to be having more often regarding LGBTQIA+ clients, especially queer and trans people of color?
Yes, there's so many. First, I would like to just say is that just like we talked about LGBTQIA+ being distinct populations, the acronym of PLC is also an acronym that captures very distinct racialized, minoritized populations who have different experiences in the United States. So I think it's very important to make that distinction. And so while I can talk about the experience of being a racialized, minoritized person in the United States, my experience is of a Black person. So it's really important that people who identify as Latinx and Asian and Pacific Islander and Native American First Nation folks, that they can speak to their unique experiences as well. The overlap is that I can talk about being racialized and minoritized. So I really want to make that distinction because that's really important. One of the things that I would really draw attention to is what is called sexualized racism. And Black and brown people typically have the experience of being sexually objectified and eroticized. And so for Black men specifically, they're often looked at as a phallus and not a human being. And so that's a problem, that's a common occurrence that happens within the LGBTQ plus community. Also, sexualized racism looks like people posting ads for relationships or hookups and saying that I'm not interested in Black men and I'm not interested in Asian men, with this idea that they're not desirable. And so that's another example of sexualized racism. And these issues are very rampant in the community. So it's very important to know about these things and to do your homework and learn about sexualized racism. The other thing that I would recommend would be that when you're working with clients who are Black and brown, that you also you address race in the room. And so often one of the big criticisms about therapists, specifically white therapists, when it comes to Black and brown clients who are LGBTQ+, is that they don't address race, and they adhere to this colorblind ideology racism, that I don't see color. Well, we know that's not true, because if you believe that, you would not have said that, first of all. And the research is showing that that's not accurate. So addressing race in the room is very important. And also having an understanding of where someone's relationship is with their racialized identity. And so what I have found often anecdotally is that white LGBTQ+ folks want Black and brown people to let go of their racialized identity and adopt an LGBTQ+IA identity. And that's very problematic, because you can't do that. It's part of your skin and your experience as soon as you step outside the door. And so that is really important to address. The other thing is to include microaggressions and racism in case conceptualizations, because it's a very real experience. There's research to support that. And I think we're really seeing that now in society, and we have the uprisings and the protests as a result. Also integrating integrating research findings and the connection between discrimination experiences and psychological symptomology is really important. So again, integrating research findings between the connection of experiences, between discrimination experiences and psychological symptomology is really important. There's a lot of research on how discrimination affects health and health outcomes and lifespan and mortality. And also assessing and ameliorating potential negative scripts as a result of internalized microaggressions. So it's not uncommon for people who are oppressed, who are racialized and minoritized, to internalize negative scripts about their value and who they are as people. Also including race and other intersecting identities in your case conceptualization is really important. And also becoming familiar with people's backgrounds, so their racial and ethnic identities, doing research, taking classes, reading books, and attending workshops. What I find is often people want quick solutions and quick answers and don't really want to invest in the work. And if you are really serious about doing this work, and it's an investment, and it's a lifelong investment that you don't arrive at. The other thing that I would mention is that we've seen the dehumanization and the lynching and the executions of Black people right now. And so it's important to really incorporate that in your work as well. and also incorporate the dehumanization of Black life. And also we see a proliferation of Black working class men being lynched and executed, as well as Black women and trans Black women as well, experiencing a lot of violence and death. And so those things have to be included in your case conceptualizations and the work that you do with your clients.
Thank you so much. Our next question, this one is for Kaden. How can you help someone that's unsure of their sexual identity?
So I'm going to expand this to just identity, right? So it might be sexual identity, it might be gender identity. And I think there's a big part of it. Sometimes there's going to be pressure from the clients to be like, what is the label that is right for me? And there can be something that's like, what's the box that I fit in? And there can be something that's very limited, because therapy really should not be about what are you, but it should be about who are you, and helping clients actually be okay with the, I don't know what it is, let me try things on. And therapists also have to work through their own anxiety of, it's okay that your client doesn't know. You don't have to give them the answer, because you cannot give them the answer. That's something that it's part of them figuring that out is the journey that is important. So you don't want to pressure your client to figure it out sooner than they are.
Great. This next question is for Nina. How do I support a client who struggles with same-sex attraction but doesn't want to come out because of religious beliefs?
So that's a really good question. And I want to break down the question a little bit as well. So struggles with the same-sex attraction. One of the things is looking at what are they struggling with specifically? Are they struggling with same-sex or same-gender attraction? I think that's a little bit more accurate. Are they struggling internally? Are they struggling externally? How much of that struggle has been internalized from the boxes that Kaden was speaking about too, of like, I have to fit into a box. How much of that is steeped in religious homophobia and religious biphobia and religious transphobia, because of this religious ideology, particularly in mainstream Christianity, there is this, God and gay can't exist together, toxic message that's also not true in that regard. And also, if it's not Christian-based religious beliefs, if it's Islamic, if it's Baha'i, if it's Jewish, if it's whatever it is, knowing that particularly I'll just speak as a clinician who's in the US. In the US, mainstream Christianity and the struggle around queerness in general influences all aspects because of the privilege that Christianity holds in our society. And so whether it's primary religious trauma in that way, or even secondary of, I'm not even thinking about going into a church, but I know if I did, I would burn, or they would at least think that I would. And going into that and looking at what are their supports, how much, how do I support a client? Well, first, what support access do they have? What affirming support access do they have? How much work have you as a clinician done around your beliefs? How much work have you done on your end of, okay, identify as, my belief system, whatever my faith tradition is or non-faith traditions are, how much of that internal work is going to be biasing me to this person's experience? So, and also like, what is their relationship with a higher power? And One of the things that also happens that I've really experienced with clinicians as well is, okay, so maybe there is a clinician that identifies as part of the queer community. Have they done the work around internalized religious trauma and how that's impacted them? Because so often there is no space, or there's very limited space for spirituality even within the queer community, despite having, I think it's like 52% of the LGBTQ population identifies as some sort of Christian, which is interesting. And so just noting that, and again, my experience and expertise is very biased in Christian focused spaces because that's just the work that I do. But really noticing, just really noticing where do I have the support for all aspects of my intersecting identities? Where does my client have that? And also looking at the pressure around coming out and the particularly the whiteness of coming out and what that looks like. For POC, there's an individualistic bent on coming out being the final goal, even though it's a process. It's coming out versus inviting people in, secrecy versus privacy. There's this belief that, you know, LGBTQ folks are intentionally being deceiving. That's particularly for trans folks, that there's connection of like deception. When, you know, for some people, if they're not a safe person, respectfully, it's none of their business. So what spaces do they have that are safe? What are the people in these folks' lives who have earned a spot of holding queerness as sacred? So those few thoughts on that.
Just a few. Thank you so much for your insight. So this next question is one that I would like to pose to all of you. I'll start with Yamonte, then we go to Nina, and then we'll end with Kaden. The question is, in your experience, what is the most common barrier for the LGBTQIA+ client in working with a therapist who doesn't identify as such?
One of the most common barriers. That's a very broad question. I would say probably the common barrier would be the therapist not doing their homework. And so often putting the onus on the client to teach them about their experiences and about who they are and overall their lived experience. And also universalizing their own experience and really looking at their experience as if that's their client's experience. And so that would be what comes to mind for me, is this idea of my clients have to teach me, which is really dangerous. And so it's really incumbent upon therapists to do their own work, their own homework, their own research. They're investing in books, classes, workshops, and not putting that responsibility upon their clients. And if you don't have that cultural responsiveness and in humility, then you probably should not be seeing these clients, because you potentially are creating harm. So that would be the main barrier that comes to mind for me, is that therapists who are not doing their work to become responsive and humble with working with various populations within the LGBTQIA+ communities.
Yeah, for me, one of the things to piggyback off of what you're saying, Yamonte, is this idea of that the barrier, it's such an interesting thing, because in my experience, I am part of the community. And so I don't necessarily know what the most common barrier would be in working for, is working as a cisgender heterosexual therapist, because I've never been one. So looking at that and going, okay, how much of this is about the clinician themselves and how uncomfortable they might be working with this population, and working with these people, working with me. Because I've also had plenty of straight therapists who have been great, and a big part of that is they didn't make the work about them. They made it about me and my experience, not about their experience. And so one of the things that I really encourage people, clinicians especially, is consultation. We talk about it when we get licensed, when we're studying for the exams. And then what happens oftentimes is we don't get the consultation that we need. We're not willing to pay for it with people who have lived experience, which is really important. So how much are you investing? If you're asking a client to invest their money and their time and their heart and soul with you, are you also willing to invest your time, your money, and your heart and soul as a therapist in getting the education that you need? Because none of us have gotten nearly the education that we've needed from our primary institutions. We got baseline. And that's not saying anything, necessarily bad about our educational experiences. It's just there is no way for a 2-year, 6-year program or whatever to be able to encompass the experiences of every type of person. And so doing the continued work is what's really coming up for me in that. And also up front, are you asking your client who identifies as part of the various communities within that umbrella, is it important to them to have someone of lived experience being part of the community as their therapist? And are you referring out? So, yeah.
That's an excellent point. Kaden, any thoughts?
First of all, the first two answers were fantastic. I work psychoanalytically, so I'm also going to be thinking about transference and countertransference. And so I think there's two main ways that when I'm supervising or consulting with cisgender heterosexual therapists that I see these barriers. One is fear of making a mistake. And so then what happens is that the therapist withdraws and isn't actually engaging because they're so afraid they're going to step on something that then they stop doing therapy. So this is where getting training and getting consultation will help you feel less afraid, so you're not afraid of stepping on people's toes and injuring. And the second part is that people don't like negative transference, right? So a LGBTQIA client may have a lot of feelings about you having privileges that they don't have. And they may have feelings of you're never going to understand me, or you have all these things that I never had access to. There can be envy. And you have to hold that and not get defensive. So this is where cisgender fragility, white fragility, heterosexual fragility, those sorts of things are going to get in the way of good treatment as well. So not only get training, but do your own work internally, not just like, oh, I know the vocab word, I got it. There's more to be done.
Thank you. This next question I will pose to Yamonte. Are there best practices when addressing issues of intersectional clients in therapy? For example, Black and gay, Latinx, and trans?
Yeah, I think I answered this with the other question. They're very similar. What I would just add would be some things that come to mind for me that I haven't addressed. And one of them is this stereotype and myth that Black people are homophobic. And so there's no research to support that homophobia is more rampant in the Black community than the white community and society at large. And so there's been a large research study that has found that that's not accurate, and that in some areas, Black people as a collective hold more progressive stances about LGBTQ+IA folks than white folks. So I think that's really important because it's part of this anti-Black narrative that dehumanizes Black people and it makes them a villain. And so I think that's really important to highlight. The other thing is that Black gay men, same gender loving men, bi men, trans men are looked at as walking pathologies. So often they're attributed to living with HIV. And so the research shows that there is a higher prevalence of HIV among Black people, and particularly Black men who have sex with men. But this is not about being more risky. And the research shows that that actually these men have fewer sexual partners than white gay men. And it's more so about access to healthcare and racial segregation, residential segregation, and being residentially segregated in these areas where you have small groups of populations who are interacting with each other and don't have access to healthcare as a result. So I think I've already addressed a lot of the things that I think are important, but these are some things that I think people just need to know because they're part of this mythology that continually is perpetuated about the Black community and about Black men.
Thank you. Yes, those are critical points. Victoria asks, what strategies do you suggest for helping LGBTQIA+ clients who are in denial about drinking? Given your specialty, this question will go to Nina.
So the first thing that comes to mind for me on this question is, where is the idea of difference around denial of drinking based on sexual and gender identities? Where, denial about drinking is it's just part of the disease of alcoholism at times. And so are we, what happens sometimes when we're working with folks in populations that we're not as familiar with working in or that we don't specialize in is that we get tunnel vision. And we're looking at okay, this is an LGBTQIA person and that's all I see. When if you're not trained and competent in working with folks who are struggling with addiction, then that's another refer out. Even if you are like an LGBTQIA specialist, how much training do you have around substance abuse? Like if you've never worked in a substance abuse setting, if you yourself have not gone through a sober journey or a recovery journey, we had one class in my education around substance use. And for LGBTQIA folks, there are higher numbers of substance use, 2 to 3 times higher, not because there's something intrinsic around queerness and transness that makes us all of a sudden more addicty. That's not what it is. However, when coping with incredible amounts of oppression, we will do what we need to do in order to survive. And so how much oppression is trying to be drank away? Are you being gaslit? Is this client being gaslit by their culture and their society, by their support groups, by you as a clinician, around their oppression? Those types of things. And also setting boundaries too. I've been seeing a lot, it's been very strange, but I've been seeing a lot of things in Facebook groups of therapists around how do you feel about a client lighting up a joint or you know, having an alcoholic beverage during session because of like teletherapy. And so addressing that kind of stuff of, okay, the idea that there's a person who is struggling, you know, who might be struggling with drinking, maybe that person also isn't struggling with drinking. Is it your own conceptualization as a clinician around alcohol of, oh, this is very bad? Are they interested in decreasing their drinking? Is their drinking getting to the point where it is now impacting their ability to fully engage in therapy in a way that you can provide care? Okay, you know, would cutting off that relationship cause more harm than do good? Meeting the client where they're at is something that is really important, and also just getting education around working with substance use. That's not just in a residential or IOP setting, is really important, because what essentially so many of us as private practice clinicians are tasked with working with, you know, folks who are contending with substance use. And a big part of our job is to look at when is just constantly assessing of, is there preventative care that we can do with this person before it gets to the level of needing that level of support? And then if you are going to be referring out to a higher level of care, then it goes into what programs are affirming. And those are very rare, very, very rare. If they have a track, that's a bad thing. You don't have heterosexual tracks in treatment, so why would you have an LGBTQIA track? You're separating the person out again. You're causing internal splitting. And so am I treating the person as a whole person? Yeah. And also, do I have referrals that, particularly if you're referring out to a 12-step program or smart recovery or refuge or whatever, do I already have on hand LGBTQ affirming spaces for them to go for recovery? Gayandsober.org is a really good kind of compilation list of meetings for that are specifically geared for and centering the experiences of LGBTQIA addicts and alcoholics, which is specifically 12-step, and looking at what that looks like. There's also on the AA website, there is a collection of recovery resources specifically for LGBTQ folks, a collection of stories and shares that are from LGBTQ experience. They also have a compilation of African-American experience in AA, because oftentimes when they get to the point of past being denial about drinking and looking at, okay, I would like to explore my other options, they'll go into a setting where they, again, feel decentered and are being decentered. And that can deter from getting services and support too.
It's very well said, and thank you for sharing those resources. Kayla asks, what do therapists need to know about gender reassignment surgery, and what needs to be included in our letters for our clients? Hayden, this question goes to you.
So first off, the term gender reassignment surgery. So it used to be called sex reassignment surgery. So you'll still see SRS, usually by insurance companies and people that are not really working with these communities. The term we're going to see more is gender confirming surgery, so GCS, or gender affirming surgery, or GAS. I think gender confirming just got more popular because the acronym is better. But when we're talking about surgery, we have to be clear about which one, because you could be doing facial surgery, you could be doing a tracheal shape to remove the Adam apple. There can be voice surgery around deepening or stretching the vocal cords so that the damage from testosterone is repaired. There can be chest surgery, and there's a wide variety of techniques that can be utilized for the chest. There's genital surgeries, and then there's some that are a little more obscure, like surgery to increase height or surgery to remove one of the ribs in order to get a more hourglass figure, and there's some others that also fall into this category. So when you're writing a letter, there are a couple different ways to do it. So there's an older model, which I am not going to recommend. I'm actually going to say don't do it, and that's the gatekeeping model. The gatekeeping model has done so much damage to the transgender community and the gender nonconforming communities. And it's part of the reason that there's a lot of distrust of mental health professionals, because I've had clients that are older that have been denied letters because they weren't feminine enough as a trans woman, or because they were a lesbian trans woman, or a gay trans man. So there are scripts that clients can find online of what should I say to my therapist. And immediately, if that's what the client is trying to do, where they're trying to convince you this is my true gender, they're thinking that you're a gatekeeper. So you have to nip that, of being like, no, I'm coming from an informed consent model. So what does an informed consent model mean? It means that if you're informed around the surgery, and you can consent to it, then cool. So if you're going to be assessing for someone to be having informed consent, you have to be informed about these surgeries. Do you know what phalloplasty is? Do you know what vaginoplasty is? Do you know what the recoveries look like? Because how else can you assess for, does the client know? And the purpose of this is not to be like, oh, you don't know, I'm not going to write the letter. Then your purpose is educating them, getting them informed, because these surgeries, if they have access to it, and then we also have to talk about advocating with insurance companies, because the provision, and this also is going to change, because the federal law around discrimination in healthcare, unfortunately, the protection that the ACA brought has been removed recently. So there's going to be a lot of feelings about that. Luckily, California still has protections at the state level. So knowing also how to advocate with insurance companies, how to fight with insurance companies, how to help your clients get single case agreements, that's all going to be part of this process that's so much bigger than the letter writing. How do we prep our clients and advocate for our clients who want surgery and need surgery to get surgery? That's our role. At least that's how I see it. What goes into the letter? It's going to depend on what the surgeon wants. There's some things that are required of the client's name, like their birth date, some sort of identifying information. There does need to be the diagnosis of gender dysphoria. So basically the letter's purpose is to denote medical necessity, which is bizarre that we're put in this role, because typically for any other surgery, it's the surgeon that makes that determination, but in this case, it's our role. So even though we might have feelings around that diagnosis, we have to talk to our patients about it, because the way the system is set up is like, you're not going to get a prescription for insulin if you don't have a diabetes diagnosis. You're not going to get surgery covered if you don't have a diagnosis. And so this is how do we work the system to help people get their needs met. So I recommend looking up WPATH. So WPATH is an organization that writes the standards of care. There are a lot of feelings that the trans community has towards WPATH, but they are the standards that insurance companies use. So being familiar with them is important. That's going to be the place. And then if you have questions about what's needed for a particular letter, call the surgeon's office and say, what do you need? And then just write the minimum amount that is required for them to get that coverage.
I wanted to take this question one step further. So after a client has had a gender confirming surgery, what kind of role does the therapist play during that recovery period?
It depends on what they need, right? So was this a client that came in because they just needed a letter for surgery? Then maybe my role is done. I advocated for them, helped them get on their way. Maybe this is someone that has low distress tolerance. And so they are in pain because they've been cut into, because that's what surgery is, and need some help with that. Maybe this is a client that just you've been working with for a while around depression or anxiety or relationship stuff, whatever is going on, and now they're in surgery. There's also something about surgery that is regressive, right? Because it's more vulnerable, it's more exposed, and so sometimes it might be around dependency needs, asking for help. Those sorts of things may be coming up in recovery, but that's going to really range much more on other things than what the surgery was in particular.
Thank you. This next question from Katie, I wanted to pose to all of you because based on all of your guys' different backgrounds, I figured that you'll have very specific different training programs and certifications that you can specifically recommend. So Katie asks, what training programs or certifications would you recommend for therapists in training looking to take a deeper dive into this? Let's start with Yamonte, and we'll go to Nina, and we'll finish with Kaden.
I would recommend the certificate program at Antioch, Los Angeles, the Antioch campus in Culver City. They have an LGBTQ+ specialization.
Great. Yeah, I'm biased in that way. As I went through the master's program and got my master's in LGBT, the LGBT specialization there. And so I am very biased in that. Looking therapists in training, so I'm looking at therapists in training and thinking, okay, how far along are these folks in their process? When you are looking at schools, kind of just stepping back a little bit before the in training part, when you're looking at educational spaces, how much centering there is there of LGBTQ experience in educational platforms, and looking at that, where are you wanting to focus, that kind of stuff. What kind of looking into the modalities that you're looking to get a little bit more training in, and the modalities, conceptualizations of transness, of queerness, looking at that. I know there's been a lot of conversation recently around reality therapy and its incredibly racist, sexist, homophobic, and transphobic origins, and what that looks like. So doing a lot of questioning in that, looking locally too, like where are my local people? Who are the people providing these trainings? Are they of experience, lived experience? Are we amplifying melanated voices in some of these areas? Am I just getting the typical like cis white gay versions of LGBTQ affirmative work? So yeah, so specifically, I would agree with Yamonte about Antioch, but also again, empowering folks to do their research of, does this feel good? Does this feel affirming to me? Does this feel intersectional to me?
So I have two biases here because I'm faculty in the LGBT specialization. And I also am the executive director of the Affirmative Couch. So we provide online continuing ed for people that are farther along. The courses there are really meant for people that are already working with the communities to gain more depth, because one of the things that I find maddening of going to another training about trans people and being like, pronouns are important. I'm like, yes, they are. They're super important, but I'm past that. I've been working with this community for 10 years. I'm part of this community. I'm good. So also, depending on where you are, you might need to find more basic trainings to build up to that. I'm not a fan of certificate programs. And the reason I'm not is because there's almost something like, oh, I have a certificate, it's on my wall, I know everything. Because it almost makes it sound like I'm finished. And the reality is, this is never finished, because there's always stuff going on, there is always changing, language is changing. Some terms that used to be accepted in the community are now offensive in the community. And so this is ongoing. So I recommend not just training programs, but also ongoing consultation, because that's also going to help with more of the internal process stuff, rather than just here's how to apply theory, or here's how to conceptualize, or here's some strategies or interventions.
Thank you all for sharing your insight and your experiences. Just for the sake of time, we are going to fast forward to our live Q&A section so we can answer some of the questions that have come in real time from our attendees. And before we jump into the questions, I just want to preface that these questions will be open to any and all of you. So if one particularly calls to you, feel free to jump in and give us your expertise. So let me go ahead and open up the questions here and see what we have. So this question, sorry?
I was just joking, the Jeopardy song while I'm waiting.
All right, well, this first question is, how do you tease out when you're unconsciously putting the responsibility on your client to teach you about their experience versus having them discuss their experiences to explore therapeutically? It's a little bit of a dense one.
So how do you figure out your own biases, right? So there are tests, the implicit bias tests on the Harvard website. You can Google it and you can figure out what your blind spots are and you can start your work from there.
Does anyone have anything else they want to add?
I think another part is, that's great for outside, but in the room, kind of when you're asking, what's the feeling behind it? Is there like a fetishizing curiosity? Is there an objectifying curiosity? Is there a salaciousness to it? If there is, then it's about you. If it's a question that you would ask anyone, just maybe the context is around gender, like what does gender mean to you? I might ask that of a cis client, I might ask that of a trans client, then you're generally going to be in the safer category. The other thing is to pay attention to the client's body language. If they withdraw and they're like, oh, and it can be very subtle, then you've probably made a mistake. And so then being like, oh, I just asked that, what was that like for you? Did that, and if they say, oh, I felt, like I had to educate you, oh, what was that like? Because I imagine that that's not the first time that's happened, and then there can be some repair. So I think it's looking at those micro expressions can really also help identify moment to moment what's going on in the room.
Nina, anything to add on this one?
Kaden kind of already brought up the only thought that was really coming to me was opening that up to the client of like, do you feel like I'm educating you? Like, or like I'm requiring education from you? Because like, that's not my, like, and also just reaffirming in the room of, I don't want you to educate me. It's my job to educate me. And if you feel like I need more education, I want to open up that dialogue and make it safe for you to say like, hey, I think you need more education around that, and being okay with being called into that. It's not our client's job to do that, but if they have the ability and the ego strength to be able to say, you know what, yeah, you kind of messed up there, being able to handle that in the moment and being like, you know what, I totally did, and I really appreciate you for telling me that and for trusting me enough to tell me that. And then go do the work. That's always the thing. And then go do the work.
Absolutely. And I agree with Kaden and Nina. And I would really pose this question to that individual who asked the question. Do you have a knowledge base? And did that knowledge base come about because you sought that knowledge and you invested in learning? And it's a dynamic process, as Kaden mentioned earlier. So if you're starting out and you haven't taken any classes, you haven't taken any workshops, you're not getting any consultation, and you haven't purchased any books, and you are there with a client from a specific population that you have no idea, and you have no idea about their lived experience, that can be problematic. So from the baseline, you can answer that question based on how you have spent your time and what you have invested in.
Thank you, guys. For this next question, can you speak to the benefits of ASEC certification, particularly when working with LGBTQIA+ populations?
So I think that would be directed towards me because I'm an ASEC certified sex therapist. So the benefit is, and of course, it's a benefit to the LGBTQ plus community and communities, period, who have sex and who don't have sex, really. It really just enhances your ability to talk about and work with issues of sexuality and sex and intimacy.
Anything else anyone wants to add on that one? When it does come to discussing intimacy and those finer points with clients, is there anything that you would recommend or suggest to be particularly mindful of when discussing those topics?
When discussing topics of sexuality?
Not necessarily identity, but in terms of when they're describing intimacy, but rather issues or things that they want to explore and discuss further.
So most therapists, they're afraid to talk about sexual intimacy and don't know how to address that. And then people come with their own internalized scripts that often are informed by religion, belief systems that they were socialized into, societal, puritanical value systems, and so forth. And so it's really incumbent upon people to really sort themselves out and really get a sense of where their belief systems came from and their value systems and why these things are important to them if they are still informing how they move through the world and how they think. And so that's really important. But you know, I work from a Rogerian non-judgmental stance. And so it's really important to really work with the person in front of you and their world. They're the expert of their lives. We have expertise in therapy, but they have a lived experience that they can speak from and draw from.
Thank you. So that's it for the questions. Is there any last minute things that any of you would like to speak to or to mention to our audience?
For me, thank you. So for me, looking at the questions that were posed, of course, we didn't get to nearly all of the questions that our registrants submitted, but looking at the questions that were posed, a lot of them are using LGBTQIA+. And one thing that's really important for me, for folks to take home from this is, yes, community, we love community, and that's really important. And we do need to lift each other up within our community, you know, always. And there are so many different experiences with each identifying point and each intersectionality that just compounds there. So I didn't see any questions that specifically talked about bisexuality. And in our community, the bisexual erasure is so huge, and that really needs to be teased out, again, on the individual part of clinicians, and also seeking specific continuing education around that. I also noticed that as far as like relationship dynamics, there were not any questions about couples work. And so is there implicit bias? I would say yes, in that the couples or relationships work, excuse me, around LGBTQ folks and partnership and the lack thereof and what that looks like. So just looking for the absences for me is important. And looking at the, like, we didn't even discuss intersex at all on this entire panel. And just noting that this is an hour long. You are not going to get all the answers. There is no quick fix to this. You read a book, then you read another book, And then you work with folks and you get consultation around those folks. You take a CE, shameless plug from for Affirmative Couch, because Caden's awesome. You read Yamonte's upcoming book around racial trauma, which I'm so excited about. You continue to do the work every single day because that is what you signed up for as a clinician.
Any other last minute thoughts?
So I would just add that some of the questions, it looked like people were afraid, like they were afraid on how to move forward. And so you have to move forward, and there will be mistakes that are made, and you can correct those mistakes and fix those mistakes, but you have to invest in this work. And I had to just inform someone today that categories are, that those in power have created categories as systems of classification that direct thinking and order our behaviors. And so what I'm hearing from a lot of the questions is this collapsing of communities, as if there's a shared experience. So there's a shared experience around oppression, but you are dealing with very distinct communities. And so I can't highlight that enough.
Well, we're up on time, but before we go, I wanted to extend a big thank you to each and every one of you. I know that this webinar has meant a lot to me, and as well as I'm sure it did to all of our attendees. I would also like to thank everyone who joined us today. A quick reminder, you will be receiving a recorded version of this webinar to the email that you registered with. You should expect that sometime tomorrow. Also, once you exit from the webinar here today, you will get a quick pop-up for a brief survey. We just ask that you take a couple minutes of your time to share your feedback and your thoughts with us. We will share that with our panelists. It's incredibly important to get your feedback on this, so we would really appreciate if you took the time. Thanks again to all of you for joining us, and have a great rest of your day.